Sure. I'm so excited to have Dr. Eric Gantwerker join us. Eric and I have known each other. I think I first met you in Toronto in 2011, 2012,
Yeah, a long
something
time
like that.
ago.
I don't know. It was at the Academy meeting, and we were interviewing Eric for a job here in Dallas. And then he eventually came, and he was like a bull in a china shop. Like, you know what? We're going to do this, this, and this, and this. And I eventually said, okay, I'm just going to get out the way, and I'm just going to follow you. And he was really, with his efforts, we got the trait program started. And of course he had opportunities elsewhere, and he really wanted to live closer to home with his family and those kinds of things. We all know how those things happen. So he left and went to Chicago, and then now eventually he's back in New York, and he's at the Zucker School of Medicine for Hofstra in Northwell. He's an associate professor of pediatric otolaryngology. He also has a master's in education and medical education. And then for the American College of Surgeons, is it a Master of Surgical Education?
Yeah, I'm an associate member of the Masters of Surgeons Educators program.
So, again, so that just speaks volumes to his interest in surgical education, in medical education. And we had a really awesome panel at the Triological Society. And I thought we could continue that by him giving his piece of the talk. He switched it up a little bit because we did a lot of virtual reality and machine learning and AI. But he's going to talk about. Let me pull up your slides again. I guess
I can pull it up right now.
Okay.
I'll pull it up right now.
Let's pull up your slides. So, future of technology enabled surgical training in otolaryngology. So I'm going to let you take away. I'm going to go on mute and turn off my video in the background. And then thank you again so much. Guys, put your Q&A in and I'll answer it for you. I know you can't see it, but I'll answer it for you. Okay. All right. Sounds great, guys. Thank you.
Perfect. Thank you, everybody. So this is an interactive webinar, as interactive as we can be. So thank you so much, Romain. I really appreciate it. Romain is very modest and was a huge mentor for me, and really, I learned everything I know about airway surgery after residency and fellowship from him, and I'm forever indebted to him. I do have some disclosures. None of them have any relation to anything that we're talking about here. I do use some company names, but please note that these are no endorsement or promotional in any way. I do have some copyrighted images and videos. These are used for educational purposes only, and are subject to copyright. I wanted to thank Dr. Romain Johnson for being a huge influence in my life, and I really want to appreciate the Medical Society for having me here, and really appreciate it. As with any education talk, we have to talk about objectives. We're going to talk a little bit about the technologies in medicine and surgery, and have some specific things in otolaryngology. The thing for us is I do want to have you all interact with me. So we're going to do that through a polling system called Poll Everywhere. So you can either go to pollev.com/GANT, or you can text GANT to the number 22333. That's 2 2s and 3 3s. Or you can even scan the QR code on the top right. And once you're in the poll, then you don't need to rejoin, which is really nice. So you should be able to see your answers as they go live. We have a few other questions that are going to be put in the Poll Everywhere. So even if you don't want to answer this, you can just put a space or something along those lines so that we can know that you are in the poll. Perfect. Awesome. 2002, lots of 2000s. 2025, nobody pre-2000. That's interesting. At least so far. Awesome. So we'll have more time to join later. You can continue to leave this open. So why are you here? It's a good question. So you all have your own reasons why you want to learn more about technology. I'll tell you why I'm here. And Romain alluded to it before, that my interest came in through the education portal. And basically what happened with me was I was very frustrated with the way that medical education was being taught. And I wanted to upskill myself as well as others on how we can be better teachers using the cognitive psychology of how people learn, which has drastically changed over the last 100 years, yet our teaching has not. The old teaching methodology was that we basically just shove a bunch of information into people's into people's brains, and they're going to walk out knowing that. We know that that's not actually how people learn. But the good news is we've changed a lot, which is actually not true. We continue to have lots of didactics and passive sessions where people are just expected to sit and listen. I don't expect that for this. I'd like for more interaction. So you can do that through the Q&A. Unfortunately, we can't have you speak live because of some people who ruined it before us, but we will have some online polls for you to use as well. The other thing that we have to understand and put into context is just the entire corpus of medical information and how fast this doubles. Remember when the medical education system went through the first transition under the Flexner report back in 1910, the doubling time for medical information was very slow. That is, how much we know more about medicine was very slow to make it into the literature. Now that number was 73 days as of 2020. It's even faster now. If you're tracking anything within medicine, you can see how fast things continue to add to our corpus of knowledge. And so what ends up happening is that you are not going to be able to learn everything that you need to know to practice medicine. You just need to accept that. But the question is for the future of medical educators and the future of medicine, how can we prepare our students for the future? And famously, Albert Einstein, when he asked about what is the speed of sound, which was a screening question to be Thomas Edison's intern, he said, I don't know. I don't burden my mind with such facts that I can easily find in a textbook. And that now is where information lives, is actually online and not in a textbook. And they have real-time information at their access point. And so we need to teach, instead of people facts and figures, we need to teach them concepts and ability to problem solve. And so that's the biggest difference that we have today. And how can we use technology to get there? The old adage in surgical training was see one, do one, teach one, made popular by William Halsted. It even predates him a long, long time ago. But this was the idea that we were predicated on experiential learning. And we no longer have that luxury anymore because of decreased time in the operating room. You've noticed that after COVID and during COVID, there was massive learning losses because people weren't allowed to come into the hospital. Simulation centers were closed. And we started to realize that this experiential learning, this in-person learning predication, was an antiquated system. And this is no longer the way that we think people should learn. Instead, what we need to do is we need to think about how a new creative system using technology can enable this educational journey, both cognitively as well as from a psychomotor standpoint. Michelangelo famously, when he crafted his sculptures, basically said that he didn't create the sculptures. What he said was that the marble has the sculpture within it, and all I'm doing is releasing the sculpture. And so that concept of us taking a marble, which we could imagine as a student or a trainee, and we start to carve that. But know that we only have so much time carving that statue. Instead, what we need to actually teach them is to carve themselves. And this concept of self-reliant learning is something that can be built using technology. And we're going to talk a little bit about how people can self-regulate using technology through feedback and assessment that is relatively seamless with a bunch of these different technologies. And this idea of self-regulated learning is not new, but White and Gruppen came out with a very famous article back in 2013. And this is sort of the cycle that people go through as they're starting to do self-regulated learning. And you can see that feedback, both self-monitoring and assessment, as well as external feedback, is extremely important for them to go through this cycle. And without that, they have no reason or no impetus to change. And this is actually where technology can provide us some opportunities. And we'll learn a little bit about how technology can actually give objective assessment of psychomotor skill, which is something we've been lacking for a very, very long time. We just sort of had experts watch them say, yeah, you're good at this surgery, let's let you do more. But now we have more objective assessments, and that's something that's been enabled by technology. So why are we talking about technology? So this is Moore's Law, and Moore's Law basically states that the number of transistors doubles every 18 months. And what that means practically is that this is a logarithmic scale with how fast technology is going faster and providing more memory. Just to put that into context, when you take the Apollo 11 guidance computer and compare that to the iPhone in your pocket, the iPhone is 900 million times faster than the Apollo 11 guidance computer, literally the computer that put the ship on the moon. And the iPhone in your pocket is 100,000 times more computing power than what it was to put the ship on the moon. So just think about the amount of power that's literally sitting in your pocket is enough to put a bunch of things up on the moon, if you want to try it. So it's not surprising that there's a lot of technology companies that are starting to enter into the world of healthcare. I could have a list that just continues to go for hours to show you all the companies that are in this space. And we're going to talk a little bit about some of these technologies, the good and the bad and the ugly, with regards to some of these. There's two main use cases. There's obviously a ton of use cases, but specifically, we're going to talk a little bit about the patient care tools that our future trainees and medical professionals are going to have at their disposal, as well as the technologies that we can use to teach them. These go a little bit hand in hand, and sometimes the technologies are the same, but the applications are slightly different. There's also a bunch of digital therapeutics that we may have time for. The most important thing that a lot of people have now realized is this is the Gartner hype cycle, which is essentially the concept that things that get introduced go through this hype and expectations curve that go up to these heightened expectations. And all these technologies we're going to talk about have gone through this hype cycle. And a bunch of them are coming down from the expectations and going down into the trough of disillusionment. And eventually we're going to go through the slope of enlightenment. And every single one of these technologies has gone through this. And as over time, you'll see that some technologies completely fell off the map, like laser discs, if you will. And some of them have been, we've realized how to use them a little bit better. So every technology that pops up is not the end all be all panacea, but we do realize that some of these technologies will change the way that we practice medicine. And that's just a fact of the matter. The question is, how do we figure out what is going to change, how it's going to change, and what we need to do to prepare our trainees for tomorrow? We're going to talk a bunch of different technologies. The two main ones we're going to talk about are extended reality and artificial intelligence. So I'm doing a choose your own adventure. So we have both at the ready. We also have other, which we can get to if we have time. I doubt we'll have time, but interested to see from those in the audience, what are you more interested in learning about? And again, you can go to pollev.com. You got to vote for your favorite, otherwise it's not going to get presented. Ooh, it's neck and neck, 50-50. Wow. Artificial intelligence pulled ahead. It's so close. Oh, wow. And augmented reality and extended reality. Oh, no. Wow, this is awesome. I can just sit and watch this the whole time. So now that you have, so I appreciate that. So now that you have an idea of where we might go, I want to know what you personally came to this talk to get out of this, because the one thing I never want to do in any kind of discussion is to not take into account what you came to learn. And so this is an opportunity for you to put up here your expectations or what you're most interested in us talking about. And I'll make sure to make a touch point on that specific thing, and we can talk about it more. Again, I'd like to have people live and be able to chat, but this is what we have as options. Oh, the chat is functioning now, huh? Awesome. See what's new in MedEd. All right. Anybody else? Medical and surgical education. Absolutely. I love it. I love it. Absolutely. We're going to talk about that. A 100%. We're going to give you actually ENT specific examples of how these technologies are using. Oh, thank you so much. Global health disparities. We are going to talk about that a lot. And especially when we talk about artificial intelligence, because it's a little bit of a double-edged sword. Chat GPT or ChatGot. We'll get you ChatGot. We're going to talk specifically about that because that's all over the news. So perfect. So, we're going to talk a little bit about those and make sure that we put those in the chat and ask questions. We'll leave some time at the end. Essentially, the biggest thing that I fear is that there's a lot of fear of technology. And what has happened over time is that, especially in the artificial intelligence space, there are people who are actually fearing for their job. But one of the things I want us to understand as surgeons is that there is no technology that's going to take over our job. There are going to be things that augment our jobs, and there are going to be things that make us easier. And we're going to specifically talk about ChatGPT in that sense. But what the question is can we use technology to make our jobs easier, get better patient outcomes. And I think as surgeons, we have to be open to the opportunity to introduce these technologies, things like augmented surgery that we'll talk about, things like simulation training, things like objective assessment of skill, including practicing clinicians. We're going to talk about that. And that's extremely important from just an open-minded adoption into surgical education and surgical training. So these are some of the technologies, the AI, XR, and the other. So we'll start with XR because that was sort of winning when I changed it. So I want to get a general sense of people's understanding of what extended reality is. So essentially, the extended reality spectrum includes augmented reality, virtual reality, and mixed reality. But I do want to get a sense of the level of knowledge that people have in the audience so that I don't talk above or below you. We talk at the same level. Perfect. Anybody else? Everybody's at the B? All right. So everybody has a little bit of knowledge. They've heard the terms before. Nobody's saying, I don't know what XR is, which is good. At least you've heard of it. Interesting. Nobody owns any devices. We'll talk about that and why that's important when we're talking about technologies and their rollout in education, the opportunity to even obtain these types of technologies. So XR is not new. Just like any technology, this technology has predated us many, many years. This is back in 1968. So this is one of the first head-mounted displays that was actually attached to the ceiling and the wall by Ivan Serlin and Bob Sproul. So this was the sort of origins of VR. Again, a lot of things got started in the military. Essentially, the biggest thing that people have sometimes a tough time understanding is sort of the difference between the different technologies. Without getting too into the weeds, just understand that it is creating a digital environment. How you see the digital environment and whether or not you see the real environment is sort of what the difference is. The idea of virtual reality is that you do not see the real environment around you. You are completely immersed into the virtual environment. So we'll talk a little bit about that and why that matters. The augmented reality is where those digital overlays are on real things. Now, it may not be that they interact with the real things, but you do see the real world. And when you're talking about vestibular ocular reflex and people getting nauseous, AR is much better than VR because you have that grounding in the actual world and you aren't only in the virtual world, which is what leads to some of the VOR mismatch and some of the nausea that happens in people with VR. In mixed reality, you are not only seeing, but you're interacting with the virtual environment along with the physical environment. Those are the major differences. And there's a whole bunch of different terms that are thrown out, and we'll talk about it. This page is just to show you that there are a ton of meanings of what virtual reality is and a ton of use cases. The best way that I understand it is there's a difference between the software and the hardware. Think of VR as a hardware. Essentially, it is the technology that you view the software through. It is not the software itself. The same software can run on your cell phone. It can run on your computer. It can run on a movie screen. It can run on any other format. But in this case, it is specially designed to run on stereoscopic vision through virtual reality headsets or head-mounted displays. Just like augmented reality can actually be viewed through your iPhone, your iPad, any of your phones that have Google AR, any of these different technologies, it's the same idea. You don't necessarily need a head-mounted display, but it's how you're viewing the software. It's not the software itself, because you can view a two-dimensional animated video, or you can watch this talk in VR. It's not necessarily considered VR because that software is not really optimized to take advantage of the three-dimensionality of the space because you're watching a two-dimensional video. Very important delineation. And when we talk about the literature, it is all over the place. From a healthcare spending, it's no surprise this is getting massive. You can see this $2.01 billion in 2020. This is rapidly increases. This is all across the world. You can see all the different technologies, including virtual reality exposure therapy. That's where actually they're using virtual reality to get people over snakes and over heights and arachnophobia by having them desensitized to these things in virtual reality. The reality is so realistic that it will actually be part of their desensitization program. It's in rehabilitation. We'll talk a little bit about pain distraction. Simulation was another thing that somebody brought up that we'll have some time. The way that I categorize information in this space is basically, what am I seeing and what am I interacting with? And the best way to understand that is there's a ton of these versions of VR, AR, where you're basically just viewing anatomy. And those can be patient specific in the sense of doing surgical planning, which is what the bottom right is. They're actually watching a specific patient segmented CT or MRI and actually viewing it in VR so they can do surgical planning. And the important thing to understand about this technology is there is very limited interactivity in the sense that you are able to cut and slice and view it in whatever planes you can, like you would on your laptop or on any other viewing device. There's not a lot of interactivity in the sense that you pull on the tissues or there's anything that gives you any feedback. It's just cutting and slicing three-dimensional rendered images. This is a good example. So this is a company that has a very high-end, the audio's not coming through, huh? That's okay. I think I've muted the audio. So you can see here this heart, again, it's in augmented reality because you can see the room behind you, but you can see how they're rotating. There's a little bit of a didactic information on the left-hand side. They can slice it, they can choose it, they can click on it. And this is sort of this anatomical viewing way of interacting with virtual reality. Again, and this is, again, augmented reality using one of those head-mounted displays. I think this is HoloLens. I can't remember which. But again, that interactivity is relatively limited to just rotating the different thing. Now, this is really important for us in otolaryngology when you talk about really complex three-dimensional structures like the middle ear, like the cochlea, like rhinology, which is a lot of the areas that we've seen these implementations in otolaryngology is otology and rhinology, because you can't see those spaces and mentally modelly create those three-dimensional spaces very easy. So it's a great place to use these types of technologies. This is a program that was done at Cleveland. This is, I think, Case Western Cleveland Clinic. So this was, they were trying to figure out how to use the HoloLens to replace the cadaver. This has been an effort that's been redone in multiple different institutions, trying to understand how technology can get us away from using human cadavers. Again, the interactivity is relatively limited to them selecting and pulling things out, rotating them and viewing them in different dimensions. But there's no like real-time interactivity with it besides sort of cutting and slicing. And unfortunately, this has its limitations with regards to learning anatomy, because again, you can't dissect, you can't cut it besides just shaking different layers off and seeing different viewed types of tissues. The next level is sort of this VR, AR simulation and haptics. Also, there's mixed reality in this as well. So haptics is the concept that you are holding something that gives you some type of feedback. Most often we're talking about force feedback. So force feedback is something that's very vital for us as surgeons to be able to understand the impact of your force. That's something that the digital space has long lacked. This is sort of what we call the holy grail of VR simulation, is trying to solve this haptics problem. We have different proxies for haptics, like you can see on the bottom right for the three-dimensional temporal bone VR simulator. These are a little stylus that actually gives you force feedback. It actually gives you vibratory feedback. We'll talk a lot about haptics and feedback and why that's important as far as the surgical education journey, but it's not vital, especially for novices who are just trying to learn the anatomy and the structures, for them to have haptics. So we'll talk about the role of haptics. The other use cases that these have utilized is these are more interactive with the virtual environment. So even if you don't have haptics, you have something like a virtual reality controller. You can see on the left-hand side where they're drilling a knee using the controller, and they can actually have more meaningful interactions that are not pre-programmed and not just anatomic in nature. You're actually interacting with the software and creating holes and cutting and slicing. And that's sort of another level of that VR simulation that somebody was talking about before. There's also sort of all different types of tissues. You'll see a lot of applications within bony areas. And that is a technological limitation of the software, where hard body physics to represent in virtual environments are much easier than soft body physics. So this is why there's not a lot of open surgery VR simulation. There's a lot of orthopedic type applications or spine surgery, because just from a technological standpoint, it's much easier to cut and drill a three-dimensional model than it is to cut and slice and pull. So I looked at this back in 2022 with one of my medical students. We actually looked at, in specifically otolaryngology, what is the current state of extended reality used in training? And one of the takeaways, not surprising, is the nomenclature is all over the place. How people define virtual reality in the literature is not necessarily what our current understanding of the space looks like. And of all the implementations within otolaryngology at the time that we did this review, all of them were VR. There was actually no AR applications utilized for training in otolaryngology. And all the ones that were done in VR were actually not using head-mounted displays. Instead, they were like the three-dimensional temporal bone, where you're wearing stereoscopic glasses and creating a three-dimensional, but not actually having the head-mounted display. Or you had a screen in front of you that had a generated 3D image that sort of made it look like it was 3 dimensions, but it really was a 2-dimensional screen. So this is where we came up with this sort of nomenclature. This is very nuanced, but just to understand that the virtual reality space is still going through this hype cycle, and people are still using these terminologies to get stuff published without it really making meaningful impact. Because that was the other takeaway that we had from this research, was that the actual educational outcomes were not there. They really weren't showing that the educational outcomes were higher level, where they're actually bringing it into the operating room. Now, that's not because they can't. It's because the way that the technologies have been applied and studied necessarily haven't done that extra step of showing outcomes, and which is very hard in education in general, but especially in this space when there's really not a good definition of what those different technologies are, what those implementations are. The level of immersiveness and interactivity is not really well defined in the literature, and that's something that we're actively working on for those in this space. So this is a good example of one of the examples. This is a 3-dimensional temporal bone simulator. So you can see the stylus here. These are actually giving 3-dimensional, haptic and vibratory feedback. So if you actually push, you can actually feel the edges of the bone. You can see he's wearing stereoscopic glasses that are creating a 3-dimensional virtual world. And so this is sort of the VR technologies that are being used in otolaryngology. Here's another example. So rhinology, like I said, is another space that is really ripe in this, because of the ability to actually see into these 3-dimensional spaces. Very difficult to conceptualize these very small 3-dimensional spaces and relationships is very difficult. So these are two areas that are really, really big in the VR space. There's not a lot in head and neck. There's not a lot in other areas, not even in peds, to be honest with you. Really, rhinology and otology have led the way in otolaryngology. And this is a sinus simulator. Again, it has a stylus that's actually holding the sinus scope. You can actually get feedback with the virtual environment. Again, this is not necessarily VR. The person's not wearing glasses, but it is a simulation that uses some haptic devices. Again, open to interpretation whether this is truly VR or not. There's been a bunch of different reviews of these different technologies. And like I said before, unfortunately, there's been a lot of variability with the applications. You can't really take a bunch of things that have different definitions and compare them, as you all know in the research. That's what's happening in VR. And unfortunately, some of the poorer implementations of VR are detracting from some of the very good implementations of VR. And the biggest thing that I can say for anybody who's interested in this space is we need to hold ourselves into higher regard and actually not use technology for technology's sake. Don't just use VR because you can. It's much more expensive. It's less accessible because not everybody owns a VR headset, as you all noted in the survey here. Not everybody owns this. Is not a consumer level product yet, and it's extremely expensive. Even the least expensive ones are in the $350 to $400 range. Until this becomes a consumer level product, the implementation and access is going to be limited. So you really need to figure out what educational outcomes you're looking to achieve with the virtual reality, and understand how does the virtual reality be a value add to that experience, and is it worth the cost and the decreased access? That's always going to be the biggest question that I put out to everybody who's interested in this space. There was a paper that came out about the challenges of actually implementing this. Not surprising, cost was a big thing. Like I said, the communications, the user attitude, which we'll talk about, and sort of the ideas of students now coming to this. We now have trainees that grew up with technology, so they did not know a world without technology. So some of the gaming and stuff that allows for some of the hand-eye coordination that's required in some of these technologies may be more native to some of these people as they grow up, and may at some point become more of a consumer level product where they have VR headsets or AR headsets in their home. It can be expensive to design. It is expensive to make it good. That's the problem. So it's really cheap to make stuff that doesn't look great, that's not very interactive. And for a long time, people are using Google Cardboard. And the problem that happened with Google Cardboard that they found out really early was the frame rate was so low that everybody was getting nauseous in the experience, because the frame rate couldn't keep up with the VOR. And when that happened, people got really nauseous. So what ended up happening was they said, okay, we need a 60 frames per second frame rate so people don't get as nauseous. Even in a 60 frame per second or 120 frames per second, which is the new newest generation, people still get nauseous, a certain percentage of people. So again, when you're thinking about using this tool at scale, think about the fact that about 15 to 25% of people are going to get nauseous in this, and there's a time limit in which people can have this experience. So again, it has to be worth it. You have to really think, what am I using this technology for that I cannot do with anything else? Or it makes it so much more transformational using this technology than anything else that I could design. Obviously, there's safety considerations. People fallen in VR because they can't see the world around them, which is why now in the games environment, you can actually see them in these little corrals when they're in the VR. Like I said, we talked about the side effects and the validation. The validation is not necessarily there for a lot of these technologies. We need to come up with a common nomenclature. We need to understand the educational outcomes that actually are being achieved and that transfer of knowledge. And I think we'll get there. We're just not there quite yet. The last thing that is a downside to some of the technologies related to VR is the actual hand controllers that you're interacting with. There is a concept of cognitive load, which basically means your mental power only has so much energy. And when you are focused so much on interacting with joysticks, when you're not going to have those joysticks at the point of care, you're spending a lot of time trying to understand how to interact with the environment and not so much on the educational content that's on the screen. And because of that, it does detract with some of the educational content, just trying to figure out with the joysticks how to interact. Once that becomes more consumer level and people more used to interacting with VR environments, that may become less. The other way to think about this is, can we use natural hand tracking? The technology is changing every day. So this is a newer headset where natural hand motion is actually being tracked. Unfortunately, the inputs are very glitchy and they're not great, because if you can imagine, if you're trying to view how movement, when your hand covers itself, you can't really see very well. So the computers have problems actually seeing the hand motion. There's ways to fix that, and we'll talk about that in a little bit. This became very crystallized during COVID when people couldn't access simulation centers, they couldn't access the hospital, and simulation went online. And the idea that I came to understand, and the idea that I continue to think about very critically, is how can we teach people without things in their hands how to do surgery? And we realized that during this COVID-19 pandemic, which became a relative accelerator for technology adoption, whether it be telehealth, telesimulation, which became a term that only kind of came up during COVID. And it's this concept of mental practice and mental performance. And this is from 1994. This is not a new concept, but can you do mental rehearsal for people to understand how they should be using their hands, what they need to achieve within the environment before they ever actually get an instrument in their hand? And the answer to that is yes. There's good evidence that we can train people remotely to do certain procedures depending on their level of expertise. In fact, novices and experts are actually best at it. It's the people who are in the middle who have problems doing that mental rehearsal. If you've used that instrument a ton, like if I showed Dr. Johnson a technique using a bronchoscope or a laryngoscope, he can conceptualize it, train it in his head, and when he actually goes in to do it, he can understand how to do it. This is how experts go to see me conferences, see somebody present on the how I do it, and they can actually put it into practice because you're actually mentally rehearsing that because you have so much familiarity with that instrument. With the novices, they actually don't have any concept of how the instrument works, so they can totally focus on, okay, what am I trying to achieve? And then when they actually get into having the instrument in their hand, they can actually work on only the mechanical aspect of trying to achieve what they already know they're supposed to achieve. It's the middle people who know a little bit, but not enough, that really need that hands-on. And so how can we change that paradigm into everything is in-person experiential learning into this continuum of learning of psychomotor skills? The idea that people can do something asynchronously and learn it on their own time at home on their own device. You can do something synchronous remote like we're doing today. There is applications in the simulation literature where people actually were doing remote surgery and remote training. You can see it here in the middle. And how can that fit into the training paradigm? And then the synchronous in-person experiential chance-based learning that happens in surgery is the highest cost, least access type training. How do we reserve that for only the things that actually need in-person synchronous training and mentorship, and move everything else outside where it's increased access and decreased cost? So the idea of virtual reality and how it's going to change healthcare is real. We are seeing the fruits of this labor, and this technology is continuing to advance every day, and we're figuring out how to best use it and how to best implement it. The last application of virtual reality that we're going to talk about is this idea of augmented surgery. So this is, again, the idea that you can create mostly augmented reality. You wouldn't want to do surgery in virtual reality unless you're doing robotics, I guess. But augmented surgery is the idea that you would overlay a digital image or picture or three-dimensional object on the actual patient while you're operating. And this is becoming a reality in many other specialties. It has not penetrated otolaryngology as much as it has in spine surgery. Spine surgery is probably the leader in this space. When you're putting in screws, you cannot see the facets, you cannot see the spinal cord. And so it's extremely important to be able to visualize that. They're actually also using this in laparoscopic surgery to be able to overlay the bile ducts and the vessels of the liver as they resect the liver. And it basically does a surface scan to match the scan to the patient. So there's lots of different techniques that we can use, and AI is being heavily relied on to be able to make sure that the match is perfect so that people aren't off even a millimeter and cause some problems. There is some applications of augmented reality, but this was not education focused. So when they looked at this, they found about 18 AR platforms. About 15 out of the 18 provided some intraoperative assistance, and then one of them was diagnostic. So you can see here, I can obviously share these out, but you can see most of these implementations are at the point of care. So point of care, augmented reality, virtual reality is a reality, and it will be coming to surgery at some time. You can see the level of evidence here, not always quite great, but we'll talk about this as the technology evolves and as we get better at actually implementing and studying it. The other thing you'll notice here that a lot of these, very few of them were actually in the US, but you can see a lot of them are rhinology, a lot of neurotology, a little bit of head and neck, and a little bit of facial plastic and laryngology, but otology and rhinology by far are leading this. Imagine doing sinus surgery and actually getting a three-dimensional overlay while you're operating to make sure that you actually access the frontal sinus in the right path, in the right way. Again, this is going to change the way that our future trainees are going to practice surgery. Here's another overlay of a lateral skull-based surgery. And again, this is a reality and hopefully will come to fruition very soon. The last application of VR, and then we're going to move to AI, is this reality, virtual reality distraction for acute pain in children. The jury is still out whether that works, but there are people who are using virtual reality goggles while they're doing procedures on children to decrease the opiates. This is, again, a lot in hem-onc when they're getting a bunch of very painful procedures, or burns patients when they're changing dressings. Putting them into that VR space actually decreases the amount of opiates that they have to use in that population. I would love to imagine what that would look like in tonsillectomies, post-hoc tonsillectomies. If anybody wants to do that for me, work with that on me, let me know. So any questions regarding VR and AR, please put it into the Q&A. We're going to do a quick run through with artificial intelligence, and then we'll leave some time for questions. We got started a little bit late, so I apologize. So artificial intelligence, in short, is essentially artificial intelligence leverages computers and machines to mimic the problem-solving capabilities of human beings. I think AI has rapidly entered the general vernacular for lay people, and now, oh, can you guys still hear me? All right, perfect. Something changed with my audio. That's so weird. There we go. So essentially, the timeline for AI, again, long predates a lot of what we considered modern AI. And so you can see it dates back to the 30s. Alan Turing in the 1950s was very famous. The Alan Turing test is actually the way that we determine whether AI is real or human. And that was a long ago. And basically what he had somebody interacting with an artificial intelligence and a human. He blinded them to figure out if they could figure out which one was the computer and which was the AI. This, for a long time, we're like, oh, we can definitely tell. I will tell you with ChatGPT these days, there are elements of it that you cannot tell if it's real or computer. And so this is becoming a reality. The Alan Turing test in media, in lay media, is now talking about the Turing test has been achieved. And now you cannot tell the difference between AI and humans. This came the very famous chess match between Gary Kasparov and Deep Blue, and it basically could compute 200 million positions per second. The way that it does this is through these very complex algorithms. Again, it's all about how to categorize information in this space. Artificial intelligence is the umbrella term. There are other terms like machine learning and the other applications of the technologies that we're not going to really belabor. Here's some of the breakdowns of some of the different types of technologies that are being used, including machine learning, natural language processing, robotics, speak to text, which we'll talk about in a second. Basically, the whole foundational model of AI is you get a bunch of data. You built an algorithm based on that data, and then you give it a bunch of tasks to do. And then it can figure out the tasks and give that feedback in order for it to figure out how to do better at the task, which is very predicated on this data that it gets. Just like anything, crap in is crap out. And we'll talk about bias in a second and how AI algorithms have been unfortunately heavily biased based on that data and how that data is collected. But essentially in medicine, there's a lot of exciting things that can happen in the AI space that we're starting to see already in healthcare. And you can see there's a whole bunch of applications within healthcare where AI is going to be integrated. AI is today. VR is probably tomorrow. AI is today. It's probably yesterday. So you've already seen this entering into our daily lives, and you will continue to see it. There is a lot of unplaced fear with regards to AI, specifically in radiology and dermatology. Anything where you have to do image analysis, AI is awesome at this. And in fact, can outdo physicians in the right data set, in the right setting. So dermatologists are very fearful of this because they obviously see diagnosis in skin rash as something that's very easily done by an AI model is a lot easier in certain data sets. Again, there is a lot of bias that gets introduced to this. There's a lot of issues with regards to the data sets that are available to the AI to train, including skin of color, that it's not great at, which is, again, a deficit that happens in dermatology as well. Now, radiologists are afraid because diagnostic radiology, if you can imagine having a human read a digital output, is kind of crazy. If you have a computer putting out the output, wouldn't you want the computer to read it? So again, these radiologists and the dermatologists are very fearful. If you as surgeons say AI is not going to replace me, wait a second. So there are robots that are now autonomous. They can actually do surgery. There was a autonomous cochlear implantation that was done. Now the computer is not quite there. This is doing a laparoscopic surgery autonomously on a pig. So it's not quite there yet. The fear of hell coming for us in 2001 is not necessarily going to be reality. But there is some essence of an excitement for how AI is going to change the way that we do our jobs. It's going to take away a lot of the menial tasks, the things that we don't want to do, and it will help us be more efficient and focus on the humanistic side of what there is to be in medicine. And that's really Eric Topol's book, Deep Medicine. If you're interested in this space, strongly recommended reading it. But essentially what he's saying is that it can bring back humanism into medicine. Something the AI cannot do is to be humanistic and empathetic. And that is something that we bring. Now, can you take away all the crud that we do, like all the paperwork and all the other charting and all the other stuff that we have to do that detracts us from what we came into medicine to do? And the answer is probably yes, and probably soon. AI image analysis is already at the point of care. This is on the right, a pill endoscopy, actually evaluating for vascular malformations in the GI tract. Again, these are thousands of hours of data that it can cull through, and using an image analysis, be able to pull out things that the radiologist needs to look at or the gastroenterologist needs to look closer at. And really this combining of the human and the AI is really what's going to be the future. How are humans and AIs going to work side by side to be able to provide better patient outcomes and try to limit the amount of errors that happen in medicine? There is unstructured data that it can actually mine through, so it can actually go through HR data that it's not been trained on, and it can actually create models of this and actually be able to perform tasks, predictive things. Again, there's a lot of opportunity for bias here, and we'll talk a lot about that in a second. But can it help us making decision support tools at the point of care? And the answer is yes, and it already is. In dermatology, in cardiac, and the emergency room with chest pain, it already has AI algorithms that are helping make decisions for clinicians and basically giving them probabilities of certain outcomes that can help guide basically treatment decisions. It's also helping with drug discovery. It's helping with genetics and genomics, these massive amounts of data that we really don't have a lot of ability to cull through all of that data. Surgical robotics, again, it can make us a little bit better with our techniques. And if we're using it in robotics, which there's a whole section on robotics we can talk about. The other last thing that I'm going to talk about is the idea of objective assessment of skill. There are a bunch of companies in this space. This is a general surgeon who has a platform that actually will do any video feed and can create an AI analysis of performance. There's a bunch of companies in the space. This is not the only one. He also does team training. So he actually has cameras in the operating room that will actually watch motion of the nurses, of the techs, of the anesthesiologists, of the physicians, and can actually recommend ways to improve the efficiency of the operating room, but also can score clinicians and surgeons, including practicing surgeons. It can actually differentiate between novices and experts and give people meaningful coaching and feedback to be able to improve skill. Long in surgery, we have not had the ability to objective assess skill. The best way we had was expert observation and maybe a little bit of patient outcomes. But now the fact that we have computer vision, we have the ability for AI to actually give us an objective assessment of skill is an exciting place to be, because now it's not on us to determine if somebody has passed into the ability to perform independently. We can use some objective metrics to determine that. Again, there's a lot of bias that gets introduced to this. And so even when they started using this initially, they noticed that there were some things that it was picking up on, and it was falsely telling people whether they were better or worse. And they had to have humans intervene, which I'll show in a second, to be able to correct some of that bias. The other things that happened, so this was an AI algorithm that was looking at chest x-rays, and it determined that the presence of a pneumothorax was predicated on the presence of a chest tube. It makes sense, but the AI algorithm didn't realize that the chest tube is already after the fact that there was a pneumothorax. So the training set was not sufficient for it to pick up on its own bias, and it has no awareness of its bias. In that specific example about how to mitigate the bias in assessment of skills, they actually had some opportunities for experts to review it and actually refine the algorithm over time. In otolaryngology, there's a ton of different use cases. Andreas Burr, who's probably one of the leaders in this area, looked at it specifically in head and neck oncology, neurology, genetics, genomics. There's a lot of different applications within otolaryngology. We can look at it, how it's looking at different assessments of images and how it can actually look at that. Again, you can also add it to the virtual reality and be able to refine those models and have better fit to actually the patient on the table with regards to the scans. I'll answer that question in just a second, Dr. Daniels. The last thing is there's a lot of resistance to AI because people think, oh, well, I'm a good surgeon, I can do better. I will tell you that there are opportunities in life where we can use technology to make us better. Would you turn off the rear view camera when you're parking your car? Would you turn off the lane departure? No, usually not, because that gives you a better chance of not having an accident or hitting something or someone. So in surgery, why would we not use these technologies to help us once they're better refined and we make sure that there's not enough bias? ChatGPT, there's a ton of applications. We can go on and about this, but it did pass the USMLE, it did pass the bar exam, but it has not taken the Hippocratic Oath. So there's still a lot of opportunity for improvement. And we're still figuring out how ChatGPT is going to help. One great way is in Doximity. Doximity has now implemented ChatGPT. So if you need to write a letter of medical necessity or a denial or any kind of pre-authorization, it will do it for you and actually send it to the insurance company. Isn't that awesome? The last thing we're going to talk about is bias. There is opportunity. Anytime you collect data, you analyze data, there's a ton of fear about bias within these algorithms. And everybody is actively trying to figure out how to improve the data that goes in, the algorithms that created. And the first part is being aware that there's an opportunity for bias being introduced into the algorithms. And thus we are constantly trying to address these gaps in the artificial intelligence to make these models better and take out and mitigate some of that bias. So with that, I'm going to stop sharing and open up the floor to questions.
All right, thank you. That was very good.
Hold on, I can't hear you. 1 second.
Oh, you can't. Can you hear me now?
Now I got you. Yeah, it was
Can
mine.
you hear me
Yes.
now? If you want to answer Dr. Daniel's question, and then we
Yeah,
can
perfect.
answer Dr. Francis' question. Francis.
Yes, thank you so much. And I'll stay on a little bit later. I'm sorry we got started late. But do I think AI objective skill assessment will eventually be used by admin insurance as RVU metric if it catches on in popularity? It's a great question. We actually had a speech this morning from somebody who does inequity at the New York Presbyterian. And I asked her specifically, they were collecting nationally social determinants of health. And my question to her was, if you collect that data, if it's mandatory to collect that data, it doesn't introduce the opportunity for insurance companies and regulators to actually introduce bias. And her answer to me was spot on. And it was, anytime you collect data, you have an opportunity to invite bias. So with any technology, there are nefarious uses. And the best way to do that is to introduce regulation, to introduce transparency so people know how these are being used, to try to mitigate some of that bias and understand how that data is being used. And that was her answer. And I think that's a great answer for this specific thing. But the short answer is I still don't think that's a reason not to use it. I still think these technologies have opportunities to do good things. ChatGPT has the opportunity to do crazy things like deep fakes and all that stuff. It doesn't mean we shouldn't use that technology. We should just be aware of the opportunity for it to be used for nefarious reasons and regulate it. Dr. Francis' question, I'm using ChatGPT a lot and I'm impressed with the output once I learned how to improve my input. Yeah, so there is a lot of prompts that you can refine the output from ChatGPT. In fact, if we had time, I was actually going to bring it up and actually use this as a platform to show people how to use ChatGPT. If you have not used it, this is your opportunity to try it. I strongly recommend it. It creates virtual patients. We had it create cases for our residents. It can create questions for your residents. You're like, hey, the top 5 most important facts about osteoporosis, or not osteoporosis. This is why I don't do otology. Otosclerosis. the top 10 most important things to know about otosclerosis. It can actually output questions that are resident level. So you just say, imagine I'm a faculty, I'm teaching my trainees how to know otosclerosis and the right questions, and will generate those outputs for you. You can refine them, but it is an extremely powerful tool and a little bit scary, but I think we do have opportunities for good to use it.
Yeah, I think the one thing that is interesting about ChatGPT is that it will give you an answer that's false. It doesn't know.
Correct.
Not telling, it's giving you misinformation. Like it'll make up references and things like that.
It is terrible at references.
I think, one of the things that I've learned about using ChatGPT is you have to, like Dr. Francis said, you have to have the input. So you
Correct.
have to be the creator, and you allow the AI to improve your creation. So it's like I don't know, like somebody come, you do the architectural design for the building, like you have a vision of what you
Correct.
want the house to be, and you sit down and talk to the architect. And then that back and forth with the architect, you eventually get a good vision. But if you just go to the architect and say, okay, build me a home, it may get what you want, but it may be not what you want.
That is such a great analogy. I love that.
The other thing I would add is, so I think, so when I write and I'm like, so let's say if I'm writing a paper and I say, I'll feed into ChatGPT and I'll say, okay, critique my paper, use these guidelines. How well am I fitting these guidelines? And it'll actually spit out and say, you've hit all the guidelines. However, you didn't talk about this. You missed this point and you missed these points. These are 3 things you can use to improve your paper. And so that's pretty powerful. So now, if you try to use it to write for you, it's probably going to be nonsense. It may be pretty good, but it's going to be some nonsense of it. But if you use it in an intelligent way, it's quite impressive.
The best quote that I heard was, it basically takes words and puts them into an order that looks like a sentence. And that like sort of crystallizes what it means to me. Is it doesn't understand the semantics of what it's doing. It just sort of understands, like, these are the keywords that I need to put together, and it can make a sentence that looks real. The one thing it is terrible at is references. It is notoriously bad. And the reason why is it actually has problems accessing databases. So it's great at accessing information online. For example, I tried to do a patent search on it just to look at a certain patent of an area that I was interested in. And it literally told me I do not have access to databases. So my thought is for scholarly works, it really does not have access to databases very easily, probably on purpose, to be honest with you. But as we refine it, there are certain elements that you can take from it. And Dr. Francis said this so true, which is it does a great first pass. You know, I asked it to define for me these terms, and specifically you can use in virtual reality, the difference in my world between serious games, gamification, and game-based learning. And it actually did a pretty good job as a first pass. And the more prompts I gave it, just like Dr. Francis said, the better it refined it. I said, okay, now imagine you're an academic researcher. So if I could give you one tip, tell it to imagine that it is somebody that it isn't.
Yeah.
And automatically it will change the way that it answers that question. So if you wanted to write a scholarly piece, say that I imagine you're an academic researcher, and then insert your prompt. It is great when you sort of have it imagined to be somebody that you want that voice to be, and it will put it into that terms. So there's a great question by Dr. Olson. What are your thoughts on how to effectively roll out AR, VR, and AI technology incorporation into ENT training? So it's a great question. My first question to you is, you first have to understand what you're trying to teach. And the second question you have to ask yourself is, can I teach that using a very low cost technology just as effectively as I can using VR? If your answer is yes, then your answer is not VR. And do not use technology for technology's sake is my biggest takeaway, and better understanding what things are very good at VR, and that is three-dimensional spatial relationships that you cannot see otherwise. Or, for example, molecular interactions that you otherwise can't imagine. And those are really good. Those three-dimensional orientations and the surgical planning aspects of VR are actually very intriguing, because you otherwise really can't conceptualize where's this tumor, where's the vessels, and that's where a lot of these companies are going. And AI specifically, I think, creating question banks using AI is actually a really good technique, because it can create board style questions that you can then use to train folks. Yes, Dr. Francis. So Dr. Taylor says, are you familiar with Dr. James Rosser? Of course, I know Dr. Rosser and his Top Gun program. So, you know, Dr. Rosser has really created this entire program around Top Gun. And if you're interested, you should definitely look into it. He is a pioneer in this area, and he's done a lot of work. He's done a lot of really good, solid research in the general surgery space and in the Top Gun space. His program continues to evolve. And I'm always following and seeing what new things are coming out. I feel like he sort of is in this sort of little niche that he fits in, has not really bled over into ENT as much. I would like to see it. But again, there's other people that are working on similar areas. There's a progression-based, a practice-based, proficiency-based progression that Anthony Gallagher is working on in the robotic space. It's very similar, but this is the idea that you have to achieve a certain very important outcome, or proficiency rather, before you can progress to the next level. So you need to be able to suture closed a wound in virtual reality before we actually let you open the wound, you know, so things like that. And there's a lot of different things. Oh, he's your chief resident? That's awesome. That's awesome. Yeah, I've met Dr. Rosser before. I was very honored to meet him. But yeah, he is definitely a visionary, and he sort of commercialized it a little bit. So there is some element to that. And there's a lot of innovation and entrepreneurship that's sprouting out of these different technologies. And Dr. Rosser really has sort of led the way with that.
All right. Well, any other last minute questions in the chat or the Q&A?
We'll also put out my email address if you guys want to reach out to me. If you want to reach out to me, please feel free. I actually can also put my QR code up in the thing here. Yeah.
And I'll, you know, this is being recorded, so I post it on YouTube. Usually it takes me a day or two to edit it down. It doesn't take that much. It's not super scientific.
I was like, I'm sorry.
Need to edit and need the activity code. So I put the activity code. It should be earlier in the chat. If you look, I'll put it in again, but it's the, oh, sorry, where'd it go?
Sorry, it's because I,
okay. Here, I'll copy it and text it again. Oops, I copied everything. All right, let's see. Can you hit copy? Yep, copy. I'm gonna paste.
Perfect. And this is the QR code that will give you, oh, perfect. This is the QR code that will give you my email address. You can also follow me on Twitter or LinkedIn. I would love to hear from you all. The one thing about these webinars that I don't like is I don't like to not hear from you all and hear your voice and interact with you. Unfortunately, this type of webinar isn't conducive to that, but please reach out to me. I'd love to have more conversations and hear about your experiences, your interest in this area as it rapidly expands and changes the way that we train our trainees, as well as the way that we may practice medicine.
All right. Maybe receive Dr. Johnson's contact. And no, I don't want you guys calling. I'll put it in the chat. It's funny. I don't know what it is, but I'm not secretive, but sometimes like people will ask me, like I'll go to work and like, hey, how was your weekend? What did you do? And a part of me is like, why are you asking me?
Yeah, why do you want to know?
My weekend.
Who are you?
I don't want to tell you that what I did, but but mine is pretty easy. It's my first name and last name at utsouthwestern.edu. Romain, and I'm also on the Twitter and the LinkedIn.
Active on the Twitter.
Yeah, and so actually Harry Barnes is going to get on Twitter soon.
Oh, cool.
I need to just get approval from the board. I need to talk to you guys, but we'll see. I don't know. With Twitter's kind of this mixed feel, like it's still very active, but
the ship's kind of going down a little bit.
Yeah, it's just like, how is it going to make it? I don't know. It's becoming a little bit, but there's still no other platform like Twitter, like LinkedIn doesn't work the same way, and nobody's using Post or Mastodon.
Mastodon, oh my God. And then there was that other one where you had the chat rooms that was really popular for a little while. I think that went away. But yeah, and hopefully I'll get some feedback, because I do want, to give similar presentations. If you have feedback for me, things that worked, things that didn't work, please, any and all feedback. I really appreciate it. Really makes a difference for me. I'm always learning from you all and would love to hear from you.
All right, guys. Well, I'm going to shut it down. Thank you so much for everybody joining us. Thank you, Dr. Gantwerker. That was awesome. And it's always a pleasure. And I hope everybody's doing well. Be safe, and we will see you all real soon.
Awesome.
Bye. All right, ending the webinar.